This has been a fascinating conversation so far, Dr. Lee. Thank you so much for sharing. I'm wondering perhaps we can shift gears slightly and just maybe you can sketch a bit of history. Surely there have been some organizations in the past that have come together and said, look, we've got to do something about this. Could you perhaps mention some organizations that have really made a difference? And I know that we've also spoken offline about potential gap arising in recent times and kind of how do you see that gap? So yeah, maybe sketch a bit of history, where we are now and where you see a potential gap.
Yeah, so for a long time, and I think Diabetes South Africa is still running, but I know particularly in KZN, when I first went into practice, we used to have fairly regular meetings where they'd have a speaker and a bit of education and invite people to come. I think with all these things, and more so, I think in 2025, there's less funding available and not for non-profit organizations and other sort of more community-led organizations. It's tricky. We do have a very strong Diabetes Alliance now, which I think is doing a lot of good work in the broader sort of picture in terms of trying to deal with things like diabetes stigma, trying to do more broad-based education. Yeah, in terms of how GPs work, we were all closely affiliated to the Center for Diabetes and Endocrinology. We worked sort of hand in hand, and a lot of us were really well trained by Larry Distiller, who founded the CDE in Hilton, Johannesburg. Yeah, and then I think the landscape has changed in terms of funding schemes and models and business things that I don't necessarily understand. So sadly now the CDE is not operating across South Africa. So there definitely is a gap in terms of providing healthcare in a holistic team way, envisaged, like Larry Distiller envisaged it. But I also think what's vitally important and figure out private-public partnerships, because there are such huge gaps in the government sector, and the majority of the people living with diabetes in this country their needs are not attended to. And how do we find a model that works for everybody, the healthcare providers, the people needing the attention? How do we make it work?
Yeah, it does seem like there's perhaps sometimes a lack of funding, lack of incentive. I mean, we've seen for, 20 plus years, a big focus on HIV AIDS being, something we need to give attention to, but it does seem like that's under control to a large degree with, antiretrovirals and, better safety measures. However, it does seem like diabetes is right up there now with, some of the leading causes of death. And obviously it just robs one of quality of life. I wasn't aware of all the different links between ophthalmology, as you said, and diabetes. Obviously, I'm still learning. I know some people, lose limbs and things like that because of circulation issues. What are some of the effects of diabetes? I mean, worst case scenario, or maybe you could just take us maybe 3 stages, like minimal effect and then maybe something in the middle. And then what are the worst case is death. What is the impact of diabetes on the body?
So I like to explain it to patients like this. What happens when you pour Coke on the floor? It doesn't have to be Coke, anything like Coke, and you stand on it, it's sticky. So anytime your blood sugar level goes above 10, so if you think about it, you've got arteries and veins and they're going all over your body. Anytime it's above 10 in the vein and the artery, that vein and artery is sticky. So every single organ can be affected. So the eyes, worst case scenario, you go blind, but you can lose vision. So we like to check the eyes, do a photo of the back of the eyes to see, because if we can see that the blood vessels at the back of the eyes are taking strain, we can do laser and we can prevent blindness. We check the feet so that we make sure that if there's a tiny ulcer, we fix it, because we don't want that to develop further. There's a very close link and a dual pandemic running with cardiovascular disease, heart attacks, and diabetes. So if you've got diabetes, you're much higher risk for having a heart attack. If you've got a heart attack or cardiovascular disease, you've got much more higher chance of being diabetic. And the two kind of do run together. And that's an inflammatory basis. And it's that same sticky Coke scenario. In terms of the kidneys, sadly, you start to drop function until you have to go onto dialysis. If you don't go onto dialysis, then you you die. So what we try to do when we managing diabetes correctly is track those numbers. And if they look like they're starting to, the kidney function looks like it's starting to drop, we ask why. Is it because your sugar's not controlled? If it's your sugar's not controlled, let's control it so that we prevent that. But a lot of people, especially if they're living rurally and they don't have access, they present to the public healthcare sector requiring dialysis or an amputation, or they are already blind. When I worked in the eye clinic at Edendale, it was about 4 years. I mean, there were many people, way too many, thousands of people who arrived blind. And they arrive with their family member in the hope that you're going to be able to change it for them. But it's too late. So, I mean, that is devastating. And yet, if they had arrived 10 years earlier, the situation could have been different. And so there's all of that that's kind of, we came from a scenario where I think our health system did function better. It wasn't as equitable, but I almost feel like it's even less equitable now. Yeah, I'm convinced we can do better. Those people are in place. There are people at the eye clinics in our country, doctors working hard. It's just that a lot of the time the boat is missed for a multitude of reasons.
What can people do if they're watching this and they have concerns that they might have symptoms or diabetes? What can people do now to get tested? What are the options typically?
So most pharmacies, you can have your sugar tested. And just a single finger sugar is helpful. It's not everything. So the gold standard is more of having a glucose tolerance test where you go, having fasted, you have your sugar tested, you take a load of sugar and 2 hours after. Although these days, because that process is long, not everybody has that time, we often do use a 3-month average of your sugar to see are you diabetic or not. No, that's also a quick, easy test. So there is actually even a spot test, a spot HbA1c. In other words, you can have your finger pricked in a doctor's office and immediately get the result, or it goes off to the lab and you get the result on the same day. So that would be the first test. So, and I think if we could even just get people to do that step, because on average, and this is across the world, not just South Africa, people live with type 2 diabetes for 10 years before they're diagnosed. And if we can get them earlier, obviously their outcomes are better.
Yeah. Are there perhaps some markers or symptoms that are giveaways or tells if someone, might be aware of, then they could, get tested early on? Is there anything to watch out for?
So the common stuff is if you're very thirsty, if you're going to the toilet very often, especially if you're going to the toilet at night. Some people don't notice that. And I guess it stems back to us not really being aware. A lot of us live quite unconsciously. So we may be thirsty and even drinking that water, but not aware that we are. And that, I think, it's like the high blood pressure. Often there's no symptoms. Or like with high blood pressure, they have a dull headache, but they'll attribute it to something else. Same with type 2 diabetes. They maybe have these symptoms, even sometimes numb feet, blurry vision, a little bit of a headache, but they're attributing it to something else. I would say it's probably the way we live, it's probably a good idea to have yourself screened once a year, even if it's just a random finger stick sugar reading. Because it's such an insidious disease that creeps up without these obvious symptoms. And to be honest, like a lot of the people that come to me who are having blurry vision and have more, or they've come because they've got an ulcer in their foot or whatever, it's been a 10, 20-year process that they've kind of semi-ignored.
It sounds to me like it happens gradually. You kind of get used to it, like it's nothing.
Maybe it happens too gradually. It's like a heart attack. Same thing. Your blood vessels like this, and for it to block takes years. But it's years of eating all those chips and drinking all the rubbish and eating the fat and sitting in front of the TV. Years and years and years and years and years. It doesn't happen overnight. And somehow we've got to change our mindsets to, how do we do that? Because, I mean, as you know, we never used to have obesity in children. It's now fairly, I wouldn't say common, but we're close to being common, and we take care of children. They're not making those decisions off their own bat, if you know what I'm saying. So there's so much of the slow-boiled frog thing going on.
Very apt analogy. And I guess, there's like the actual ignorance, then there's willful ignorance, because, the incentives are there to just keep doing what we're doing. But very often you can see the lifestyle and the eating habits of the parents going down to the children, and you can see the same things showing up time and time again. So that is definitely something to watch out for. I suppose as parents, we have much more of responsibility and to become more aware of these things. Otherwise, that will continue, generation after generation. Two things I'd like to touch on before we close off this conversation today, Dr. Lee. The one is technology could be, it's a double-edged sword. On the one hand, potentially that could be the cause of some of the obesity aspects, watching TV, playing games for hours, not going outside, not getting exercise. But at the same time, on people on their phones for hours and hours, addicted to social media. But also technology can also help people monitor their glucose continually, I believe. Is that something, is that something that's emerging and changing and becoming more user-friendly, or is that still very expensive and unaffordable to a lot of people?
Unfortunately, still very expensive, but it's a game changer, particularly for children living with type 1 diabetes as well as adults. To me, it's the one intervention that really shifts the needle. So if you think about if you're type 1 and you're pricking your finger, which is painful, or you're pricking your child's finger, if you're wanting to get enough data, you need between 4 and 10 pricks a day. So that's a lot of pricking. Okay. And that is not even enough information. Okay. Because if you think about it, if you're on a CGM, if you're on a continuous glucose monitoring button, feeding to a phone of the child and the caregiver, or a reader and a caregiver, you're getting 240 readings in a 24-hour day. And those readings are life-changing, because when you see that graph and you see you ate the pasta and it went to 30 and you didn't feel well or whatever, and then you overcompensated, you gave too much insulin and then you had a low and then you felt unwell, versus you see the graph of when you had the salad and the protein and the graph is nice and stable and you feel well. There's nothing else that changes people's behavior like that. It is literally a light that goes on. They see it and they are actually motivated. It's a different type of a motivation. And so in my ideal world, the price of these things, yeah. And I do think that, technology, they're looking at contact lenses that you wear to measure sugar. There are some watches on the market that claim to measure sugar. I really don't think those are accurate. But I do think that is where we're moving towards in the future. And, a lot like the HIV pandemic, it took a lot of noise for those people's lives to matter. And now, like you say, it's a chronic disease. If you think about it, when we first had ARVs, the cost of a simple ARV was $3,000 a month, and they brought it down to $300 a month, and they did it in a few short years. And because there was quite intense public pressure, and you wonder, do we need intense public pressure? Like, what do we need? But almost certainly the technology will improve and the cost will come down. And that is one of the answers to helping people.
A ton of sense. So last point, I was just thinking, we've had conversations about medical aids and how they sometimes, are okay and good, but other times they really do fail a lot of people purely based on, the economic drivers that push them to make more money and then obviously, pay out less money to certain people. Is there some advice or wake-up call for, these companies that you would say how it could be in their interest to help and better serve people with diabetes?
Are you talking about the technology companies that are making
Sorry,
the CGM?
medical aids specifically. Yeah, no.
Medical aids.
Perhaps you could speak to that too. But I was now thinking about my last point, which is medical aids, and I know we've had some conversations about those, shifting gears a bit to what it'll take for, what kind of medical aid do we need potentially to better serve people with diabetes, and how it could also benefit them, to be more preventative, for example.
Yeah, so I definitely think that the better you manage diabetes, the more closely you can get the people living with diabetes to have a nice even sugar. So it's not even to me about the 3-month average. It's more for me a better time and range, which means more sugars in the normal range, will mean directly that funders, medical aids, spend less on the complications of diabetes. Yeah, so for me, whether it comes to funding a good insulin, funding a continuous glucose monitor, to me, this is a no-brainer. I'm not sure, and I don't understand the financial intricacies. I don't understand the back picture to the insurance industry and being reinsured and stuff that might happen between hospitals and incentivizing people to be admitted to hospital. I don't know what the dynamics are there, but to me, it's a no-brainer that medical aids fund the best possible care for diabetics for their own interests, never mind the patient's interests.
Yeah.
Look, and I think we're moving towards a place where even the funders are realize that being able to track data, being able to manage patients in a coherent team, where the funder is part of that team and we're not fighting each other, I think we're getting to a place where we can start to, because I think this country particularly has infinite possibility because of our people. Like, really, we have incredible people and we know how to back each other when the chips are down. We know how to fight for each other. We've proven it with HIV, and other examples. Even the riots, proved how amazing we are. We back each other. And so in this fight against diabetes, we can do it. I have no doubt we can do it. And we can actually, if we realize the synergy of us all working together, as opposed to fighting each for our market share, whatever, there's so much that can be done.
That's something to look forward to. And hopefully we can reach that critical mass and that momentum, that positive momentum, because I think that's when people will sort of realize, oh, hey, this can actually be done. It's not so hopeless. Maybe I can join and put my effort and energy behind this. But it takes a few committed people to start that momentum, and it's not necessarily easy at the beginning. But you're one of those pioneers. Dr. Claudine Lee, thank you so much for the chat. I really appreciate you being here and really enjoyed chatting to you. Thank you so much. Appreciate it.
Thank you, Stian, and thanks for the opportunity.